Thank you everyone for joining us. We'll begin in just a few minutes. Thank you for joining. We'll begin in just a few minutes. Thank you all for joining. We're going to go ahead and get started. Welcome to ASAP webinar series, USAID, HIV testing services, and HTS. My name is Susan Melnick. Sorry, let me put my screen on there. I didn't realize I didn't have my camera on. So thank you very much for joining us today. I'm really excited to introduce you to the USAID OHA HTS team. We have Blessing Falade, Chelsea Douglas, Jessica Rose, and Liz Manfredini. And we're very excited to be introducing them. And we also have several local partners that are going to be presenting as well today. So thank you all for joining us. I wanted to explain a few things before we get started. There's a Q&A box at the very bottom of your screen, and that's what we're going to use for all of our questions today. So if you don't mind, please put your questions into that box and not into the chat box. You can certainly use the chat to talk to each other and to interact with the panelists, but it's best if you have specific questions to put them in the Q&A. We also have a poll at the very end. About the last 30 minutes, we're going to launch it, and it's going to pop up on your screen. And that's just a poll about the webinar and for you to give us some information about how you thought today went and about future webinar topics. We're going to email all attendees a link to the ASAP website, and the webinar will actually be recorded and put on there in a couple of days. And we'll also have a slide handout as well as a Q&A document. So if we don't get a chance to answer all of your questions today, we'll be able to send that to the team. They're going to answer them there, and then you'll be able to download that document. So look for that in your email. Don't forget to check your spam message, your spam folder as well, because sometimes it ends up in there, unfortunately. So to date, ASAP has broadcasted 41 webinars. We've had more than 8,600 attendees, which is pretty wonderful. We're so thankful for all of you for being here. You'll be able to find all the past webinars at this website, intrahealth.org/ASAP resources. And I'm going to go ahead and put that in the chat as well, so you'll be able to click on it at the end of the webinar. We have several upcoming webinars. And so we also do some in French and Portuguese. So stay tuned. We'll be adding more to the list as we go. And as for that, I'm going to pass it over to the USAID team.
Thank you so much, Susan. Good morning, good afternoon, and good evening, everyone. Thank you so much for joining the Accelerating Support to Advance Local Partners 2021 webinar focused on HIV testing services. I'm Liz Manfredini, and I'm the co-lead, along with Vincent Wong, of the OHA HTS team. There's been a lot of preparation and support that has gone into this webinar. A huge thank you to the ASAP Logistics team that is supporting us today. They are Fikrate Keith, Jeffrey Brown, and Susan Melnick. An additional giant thank you to our 4 local partners who will be speaking to us later in the webinar and who we will introduce before each of their individual presentations. And lastly, a thank you to Chelsea Douglas, Blessing Faladay, and Jessica Rose on the OHA HTS team for the heavy lift in creating this slide deck and coordinating this webinar. Next slide, please. You may be wondering who the OHA HTS team is. The HTS team is actually comprised of 13 individuals across branches and divisions throughout OHA who work collaboratively to support HTS in 52 countries across the globe. On the left side of this slide, you can find the list of our senior advisors and their emails with specific countries or regions that they support. You'll hear from some of us during this presentation, including Jessica Rose, the SI lead behind everything we do, as well as Chelsea and Blessing, who are the superstars behind all of our team processes and deliverables. Next slide. Over the next 2 hours, we will cover some highlights from FY21 Q1, HIV self-testing, safe and ethical index testing. We'll share some best practices for data sharing, and then we're going to hear from our 4 local partners who will present to us some highlights and best practices from their programs and countries. Next slide. Moving on to give a global overview of our Q1 results. Apologies, since I know Q2 data has already been submitted to Datum. However, we are a day short with this webinar and having access to that data. Overall, at the end of Q1, we're at 31% for HTS-TST and 23% for HTS-TST pause. We've also achieved 21% of our global HTS self-target. Looking more specifically at these results, we had 24 OUs who are on or close to target, 3 OUs with overall underperformance in both HTS-TST and HTS-pause, 5 OUs on track for testing but underdiagnosing, and 12 OUs who are clearly over-testing, though in a few OUs you can see that they are also overachieving on case identification. For example, Nigeria, who's at 39% tested and then 76% diagnosed. It's also important to remember that global testing targets decreased 34% from FY20 to FY21, which may be impacting performance. And additionally, COVID-19 is still impacting HTS implementation and achievements to targets in numerous OUs. Rounding out our performance, we have 15 OUs who are achieving their HTS self-target. Next slide. Breaking these results down to look at HTS-TST achievements by modality, we see that other PITC continues to be the largest driver of testing volume by far compared to any other modality. The next modalities in order by volume are PMTCT ANC, Community Mobile, VCT, and Post-ANC1. You'll note that 2 of these modalities are what we refer to as HIV testing for prevention monitoring, and not a modality where we are really seeking active case finding. Next slide. However, it's important to keep in mind that other PITC also continues to be the main driver of case finding, having the highest volume of HTS-TST pause, and it's identifying more than double the number of positive individuals than the next highest modality. You'll notice that Community Mobile, followed closely by Facility Index, have the next highest volume of case finding, But of note, community, followed by facility index testing, and then TB have the highest positivity for modalities. So you can see that despite having a high positivity, the TB modality has a much lower volume of case finding compared to the 7 higher volume modalities that's ahead of it on this chart. Next slide. For index testing, we ended at 14% of our target for HTS via the index modality for Q1. And we reached 25% of our HTS pause being identified through index testing. I want to highlight that in COP19, the standard was to offer index testing services to identified PLHIV, which we set to be all newly diagnosed individuals. So we used the proxy metric of HTS-TST pause. However, in COP20, this has changed to include not just all newly diagnosed, but also all virally unsuppressed individuals. You can see that we still have significant work to do to meet that standard, since it was only at 58% of that proxy metric for Q1. And we continue to move forward to ensure that all missions and IPs are aware of this change. Also, please note that OGAC has removed the previous benchmarks that applied across the index testing cascade. Those benchmarks are the 1.5 contacts listed per index, the 80% offered to accepted, and the 80% of contacts listed to tested. From the MER guidance, the COP guidance, and all the index testing tools found in the PEPFAR SharePoint. However, please note that the minimum positivity target, the yield, of 15% has not changed for OGAC. Next slide. Even though the metrics I just mentioned are no longer applicable as benchmarks to meet, they do still have value to review from a programmatic perspective. And if we look comparatively at community versus facility index testing, you can see that across all metrics, community index testing is more efficient and more effective than facility index testing, though at a much smaller scale. Next slide.
Thanks, Liz. And now we'll go into our first Q&A break. Susan, have there been any questions that have come through the chat?
Yes, we have a couple that have just snuck in. So let me take a look here. The first one is, what is the reason behind the SD result being negative and the Avon result being positive? I'm not sure if that was written quite as meant.
I'm sorry, Susan, I think I'd need a bit more context to answer that question, or if there's a specific slide that question was referring to. But we're happy to come back to that with a bit more detail for that question.
All right, no problem. Next question is, with PEPFAR shifting from community testing, which has been instrumental in ensuring sexual partners are reached, what option do countries have in reaching the same consideration that this has always been difficult from the facility level? I'm not sure this one is a question specifically.
Thanks, Susan. Sorry, I'm just reading over that question.
No problem.
I think we can come back to this for a bit more, a more thorough response later, but I think the question overall is, and I would point out that shifts in our testing approaches, sometimes they are global and come out with our COP guidance. However, other times they're also OU specific, they're country specific, and those shifts may get decided throughout our country operational plan process that happens every year. I do think that over the past 4 quarters, we've seen a large emphasis especially due to the impacts of COVID-19 and restrictions on physical movement and a decrease in facility access, a lot of our PEPFAR programs have shifted to really leverage our community modalities. I think if we're talking about ensuring that we reach all sexual partners, that's really where index testing becomes instrumental in our programming, right? So with our index testing services, which can be either at the community level or at the facility level, and there is a lot of leeway between those two, and they're very connected. That is really where we want to ensure that we're offering testing services to all elicited sexual partners or needle sharing partners and all biological children under the age of 19. So I think ensuring that we continue to utilize index testing services, really ensuring that, and we're going to hear a bit more from Chelsea Douglas later on safe and ethical index testing services. That's the best way for us to ensure that we're reaching all sexual partners and contacts who may be listed by an index client.
Excellent, thank you. Next question is a two-parter. What benchmarks can we use to gauge performance in index testing after the removal of the benchmarks? And the second question was, why were the benchmarks removed?
Thanks, Susan. I'll take a quick answer at this, and then I'll turn it over to Jessica Rose, who's our SI lead for everything. The benchmarks were removed as metrics that countries would be held accountable to. So despite their removal in that capacity, I think they do have worth for review on the programmatic side. So I think as an HTS team, one, we're actually glad these metrics were removed and that IPs and our OUs are no longer held accountable to them. I think we're well aware that all testing services should be voluntary and require consent, and we want to uphold the WHO 5Cs. So in that respect, the benchmark removal from documents on the ODAC side was a positive step. If we're talking about gauging performance, I do think it's still worth looking at these metrics to get a better idea of improvements needed within our services or where we actually may be having successes that we can highlight. So just to kind of get that differentiation. And as to the removal of the benchmarks, I'm not quite sure why the benchmarks were removed. However, I would take a guess that this is ODAC kind of listening and then responding to CSO concerns regarding safe and ethical index testing and really trying to remove metrics and starting to remove some targets that may create any issues. So I think it was really a response to some of the fantastic advocacy from our CSOs. Jessica, anything to add to that response?
No, I think that's good. I think it's important that the benchmarks are still metrics you can use, but they should be used as appropriate to your specific program.
Awesome. Thank you so much, Jessica and Liz. Next, we're going to move into HIV testing with Liz.
Great. Thanks so much, Susan and Blessing. So we're going to continue on and talk about HIV self-testing. As I stated earlier, we continue to take positive steps with improving our self-testing achievement with having 15 OUs close to or above their target, and we reached 23% of our global HTS self-target. When we look into how we are actually utilizing self-testing, we see that the majority of tests, 53%, are unassisted distribution. And please note that this has actually been a change since COVID-19, as prior to that, the majority of our distribution was directly assisted. We do have limited reporting on the optional disags for unassisted self-testing. However, with the reporting that we do have, we see that 45% have been distributed for self-use, 39% have been distributed for use by sex partners, and 16% were distributed for use by others, which could potentially be peers or individuals in risk networks. When we look at who we're distributing to for key populations, the majority, 62%, are really going to female sex workers, 33% of kits are going to MSN, and 2% are going to both PWID and transgender individuals, and a very small number, 0.3%, are going to people in prisons and other enclosed settings. Next slide. With the disruption to traditional testing modalities and facilities due to COVID-19, USAID has continued to scale up self-testing as an approach to continue providing essential testing services during the pandemic. We can see in the top visual that USAID distributed 474,000 test kits in FY21 Q1. This is more than doubling the number distributed the same time last year. You can see that our programs have continued to make progress with distribution from 2 years ago when we first introduced self-testing. We still have a long way to go with self-testing, but again, we're continuously seeing those improvements. And every OU and IP is really critical in USAID being successful in achieving our global HTS self-target. Next slide. And as we strive to increase the distribution and use of self-test kits, we need to ensure that we have a framework for a core minimum package that includes a self-testing kit plan for procurement of commodities, programming components for distribution, a strategy for demand creation, and reaching target populations, and an M&E plan for data collection and monitoring of outcomes, as well as including linkage to confirmatory testing when feasible. Next slide. We've also had improvements on the commodity side with diversifying the market. We only have preliminary COP21 procurement data, but with that, we've already seen blood-based assays being procured for several OUs. And Unitaid just announced an agreement with Viatris guaranteeing a $1.99 price point for the Mylan self-test kit. Just as a reminder, there's currently 4 WHO PQ'd HIV self-test kits. OraQuick is the only oral fluid assay, and the other 3 are blood-based assays. And there is also currently another blood-based assay that's going through the PQ process at the moment, so hopefully this list will be expanding in the near future. Cost-wise, if procured through JHSC RTK, the pricing differs between kits depending on any offsets, such as the $1.99 price from Unitaid of the Mylan kit, or the Gates subsidized price of around $2.25 for OraQuick. Also, please know that these prices are before logistical shipping costs are added, and that in some countries, the local distributors will have a much higher price. And we also do see that if IPs procure themselves, the costs tend to be substantially higher. Next slide.
Thanks, Liz. We're going to move into another Q&A break. Susan, did we have any questions come in on self-testing?
Yes, we do have, actually, most of the questions appear to be on partner testing. So if we wanted to move on, we could answer those questions a little later.
Okay, sounds great. So we're going to move on into safe and ethical index testing with Chelsea Douglas.
Thanks, Blessing. Next slide, please. I'd like to begin with there's no such thing as zero risk. All HIV testing programs involve some risk. This risk level may be increased for index testing due to possibilities for accidental disclosure of confidential information regarding the client and his or her partners, violations of consent, and other adverse events. PEPFAR recognizes the importance of providing all HIV testing services in accordance with internationally recognized standards to ensure the provision of safe and ethical HTS to all clients. To that end, PEPFAR-supported sites must comply with the following minimum standards for safe and ethical index testing, and that will be discussed on the next slide. Next slide, please. As we work to continue to scale offering of index testing services, we need to ensure that they are safe and ethical, that they meet the WHO 5 Cs, are completely voluntary, are client-centered, and that services are never withheld from clients and clients are never pressured into disclosing the names and contact information of their partners. Next slide, please. In response to concerns raised by CSO, PEPFAR worked to create a safe and ethical index testing site assessment tool. The tool is comprised of 33 questions that address the 5 Cs and is designed to assess whether PEPFAR-supported sites providing index testing services meet the minimum standards. PEPFAR requires all sites and personnel involved directly or indirectly with index testing to meet minimum program requirements. Every site is required to undergo one baseline assessment with a potential for follow-up if they do not score 33 out of 33. All IPs serving all populations must verify that each facility and/or community site providing index testing meet these standards. Sites not meeting all minimum program requirements should take immediate steps to ensure that they are able to meet these standards, as our ultimate goal is to deliver services that meet the minimum standards. There were 3 top issues identified through the baseline assessments. These include adverse event monitoring systems, IPV first-line support training, and SOPs for those with IPV risk. The PEPFAR Safe and Ethical Index Testing Toolkit that you see linked here can be found on the PEPFAR Solutions platform. This is an outward-facing platform that's aimed at partners, and there you will find resources such as training materials, IPV and GVC risk assessments, the REDCap site assessment tools, and other visualizations for reporting results. And this toolkit was developed in collaboration with KP and GBV colleagues. Next slide, please. As of April 1st of this year, the index testing site assessment data should be considered preliminary. OUs are still submitting data mostly from follow-up assessments for sites that had completed baseline assessments but had not yet met the minimum criteria. Each respective agency is still in the process of working with OUs to review and clean data. OUs need to work with their IPs to check for inconsistencies. An end date for final submissions has not been established. However, given the setbacks with COVID-19, OUs will likely have until the end of 2021 to submit all of their data. On this slide, you will see that to date, 5,345 surveys, this includes first and follow-up surveys, have been completed. This is impressive, and we've managed to do a lot. And just to be clear, that this reflects USAID only data as CDC tracks their sites separately. Recall that there are 33 questions in this tool that span across 7 categories: counseling, informed consent, confidentiality, connection to services, IPV, training and support supervision, and adverse event monitoring and response. To date, the average score from these assessments is 26.9 out of 33, and the median score is 28 out of 33. We're very grateful for the many creative methods employed in order to safely complete these assessments. Next slide. We can get into some Q&A. Thanks, Blessing.
Thanks so much, Chelsea. Susan, I'll defer to you on Q&As from the chat.
Sounds good. So we have a couple. First one, are partners expected to provide targeted index testing? For example, testing only possible high transmitters, or provide index partner testing to all eligible partners?
Thanks, Susan. I think for index testing services, we don't want that to be as targeted as, well, index in general is pretty targeted, but we don't want it to be that specifically targeted, only looking at high risk individuals. Index testing services should be offered to all individuals who are sexual and needle sharing partners or who are biological children that are disclosed by the index clients themselves. So please don't feel that you need to target index testing services any further than those. We really do want to ensure that we are reaching those populations who may have been exposed or at high risk. And that really is all sexual contacts, including primary and secondary contacts, all needle sharing partners, depending on the country context, and then all biological children.
Wonderful, thank you. Next question, are there any models, including ICT, that have been used elsewhere to improve reporting for HIV-ST after secondary distribution? We seem to have a challenge in getting screening results from clients. We've been following up on results via phone calls or through clients giving the kits to hand over to their partners.
Thanks for that question, Susan. I'll also defer to Jessica after I give a quick response if she has anything to add on this. So I think, one, it is important to remember that for PEPFAR, the MAR requirement is just to report distribution of self-test kits. And there also are some optional reporting disags if it's unassisted or assisted, those are user type, and that's self, sex partner, or other. And then we have the KP optional disags on what specific KP populations may be reached. So there is not a requirement for MR or PEPFAR to report on use of if a self-test kit is reactive or non-reactive. With that being said, though, when feasible, we do recommend that partners try to provide information, or if it's facility-based distribution of self-test kits, then try to link individuals who may have a reactive self-test to confirmatory testing, and then throughout the cascade, linking them to treatment and other services, or if they are high risk and negative, linking them to prevention services. We realize the challenges with this. There have been some successful ways, especially that have increased during COVID-19, of IPs being able to collect some data back from individuals who have received self-test kits. Usually this is through virtual or mobile. We have some IPs that are using apps to do this. Those apps can just be a QR code on the self-test kit itself, a phone number to call, or an app where you can chat with a counselor or get more information from an individual. We also have some IPs that are using WhatsApp or other platforms to provide more information and counseling if needed to contacts when they are using self-test kits. I would say we can share some of these best practices and highlight some of the slides from prior presentations we've done as an OHA HTS team. But I would say that with self-testing, it is hard to know who the end user is. And we don't always know, especially with secondary distribution, where that test is going and who it's reaching. And at the moment, that's okay. We really want to have data collected when feasible and possible. If we're doing distribution for use at a facility or another context, but really when we get to secondary distribution, that is a lot harder. And that's where providing any information with that self-test kit can be helpful. For instance, we have countries who you can order or be distributed safe boxes or other kind of boxes that are a self-test kit, but also it has more information on lay counselors or social workers phone numbers that you can call in case you have questions. It tells you where to seek services if you do have a reactive test, so you can get a confirmatory test. So I think the more information we provide, the better. Jessica, anything to add on that?
No, I think that covers it. The only additional thing I would suggest is if you do have intake forms for regular HIV testing, that may be an opportunity to ask what brought someone to the facility that day, if they had previously taken a self-test and if that brought them to the facility. It will underreport the number of people, but it is a way to capture whether or not that kit was used and the result, and then the resulting behavior.
Sounds good. Would you like another question, or would you like to move on and we can answer them in the next break?
I think we can take one more question, Susan.
All right, sounds good. Are there any lessons from using private pharmacies in distributing HIV/ST and getting results back?
That's a great question. And I think expanding self-testing and our coordination with the private sector and pharmacies is a critical next step in self-testing for PEPFAR. And it's something that we at USAID are really working on, and we have a whole private sector team and an individual who has been working on that for a while. There are some good examples. One that we saw during COVID-19 of IPs leveraging private pharmacies and other businesses also as kind of agreed upon distribution sites for self-test kits. So what we saw in some countries with a couple IPs was that they'd virtually communicate with a client who would request a self-test kit, be this on a virtual platform or through the phone, and then they'd set an agreed upon place on where that client could then safely, while socially distancing, go pick up a self-test kit. And we had a lot of countries and IPs who had made these collaborations with private pharmacies. And that was kind of an excellent distribution strategy. There is a lot more work. We actually had a whole USAID mechanism that was working on private sector distribution for self-test kits. A lot of that work was done in Uganda. Some of it was done in Kenya. And I think we're happy to share some of the materials that came out of that with everyone attending this call, so we can ensure that we get that out to you. But there is some stuff being done in the private sector. It's still small scale, but I think we are kind of improving with being able to work with pharmacies and other private sector businesses and entities.
Perfect. And I think that'll conclude this Q&A break, if that's all right.
Yep, sounds great. Thanks, Susan, and thanks, Liz and Jessica, for answering questions. Next, we will move into our section on best practices for data sharing with Jessica Rose.
Great, thanks. Okay, you can go to the next one. So we wanted to share some of PEPFAR's data sharing principles, which are important where we share personal information on the communities we serve. The first question you should ask is there a need to know? Does the data requester have a need to know? In other words, is access to the requested data necessary in order for the person or organization to perform the work that they have been asked to do? If yes, then proceed to the next question. And if no, then do not share the data. The next question is, what data do they need? It is critical to be as specific as possible when describing what data the requester needs, what you have the authority to share and for what purpose. Ownership impacts what we can share and for what purpose, as well as who needs to clear on the release of any output products. Can the data possibly be de-identified or aggregated? Does the requester need all variables or only certain ones? The next question, how will the raw data and outputs be used? What is the intended use of the data being shared? Is it for a one-time analysis, or is it to feed a system that others will have access to? Who is the audience? Who do they want to share the outputs with? Are there concerns over disclosing sensitive details about marginalized populations to potentially insensitive stakeholders? Could an implementing partner use the requested data in a way to gain specific competitive advantage in a future procurement activity? Are there specific strategies in place to mitigate these risks, such as securing the data with encryption? And finally, clearance on public-facing products using the data shared. Output products that use data require clearance by the respective data owners in order to make the products public. If ownership of the data in question is commingled or mixed, then all owners will have to clear. Next slide. To make sure all of the necessary information is clear to everyone, we recommend putting agreements in writing. Data sharing agreements must be developed and signed by the owner of the data and the data requester. The document must explicitly address the following aspects of sharing: justification for sharing, otherwise known as that need to know, the scope and granularity of the data to be shared, what the data will be used for, and who the outputs will be shared with, and then finally, any restrictions and limitations on the use of that data. Next slide.
Thanks so much, Jessica. We'll move into our next Q&A break. Susan, are there any questions?
Yes, we have two. So the first one is, how often should assessments for sites be done in the year, taking into consideration staff retention as well as internal country shifts in policies?
Thanks, Susan. I think if we're talking about the index testing site assessments, the main intent was that this was going to be kind of a one-time snapshot of where our programs stand, what improvements we need to make, and what we're kind of being successful in and already have covered in regards to safe and ethical index testing. We did give guidance that if you don't have the score of 33, that we should work to address the root causes of those issues at our sites or at a wider scale at our IPs. And then after a period of time, you should reassess. Most of the site assessments we currently have, those are the initial site assessments. And at the moment, we haven't really, the intent wasn't to kind of continuing to reassess unless you are not meeting the standards. I will say that I think we're discussing this on a broader scale in the interagency space at PEPFAR because the platforms, i.e. REDCap, that we're using for these site assessments, that's a quite data intensive, high LOE platform to use to monitor all of our global site assessments. We are working on seeing how we make this more sustainable. Some countries are working on that themselves. Some IPs are working on that themselves. They're incorporating these site assessments into their own procedures and SOPs as an IP. On the PEPFAR side, we have not done that yet, and we have not given guidance on how the frequency of these, or if we will continue to do these site assessments. I would say that if we do continue to do them, the platform will most likely change. We've talked about trying to just utilize SIMs, which everyone has to do anyway, and would be a much easier kind of platform and process to kind of move some of the questions and the site assessments into that. Jessica, anything to add on that?
I think the only thing I would add is that what we're seeing in some cases is teams going out to assess a site that will be providing index testing services, or they have plans, and this is just an opportunity to understand where that site currently sits. And then subsequent assessments are to measure once the site is operational. So you'll see maybe sometimes where you'll see a second assessment, and that may be because they were just preparing a site to become an index site.
Excellent. We do have a follow-up question about assessments. What explains the wide range in the number of assessments done across countries? How long do the assessments take, and to what extent are the results used? What does the average really mean in terms of quality, and is that an acceptable standard?
Thanks for that question. I'm going to try to open that one up because there are a lot of parts to that. So yes, the sites vary drastically by countries, but I would note that our number of sites as USAID, respectively as CDC, also vary drastically by countries. So it's not, that's just an OU programmatic difference. You'll know that, or you'll see that South Africa by far has our highest volume and number of sites. So they're going to have a much, much, much higher reporting of these assessments than, our much smaller countries. And that's why you see some countries that only have, a handful of site assessments done. That's because in some countries, we really only have a handful of sites that are implementing index testing. It's also important to remember that this assessment is really just for sites that are implementing index testing and not really looking at all of our broader HTS services. I think that, sorry, I'm still trying to find the specific question so I can ensure I answer all of the parts of it. There are the overall score, I would say, may not be, actually, it's not an accurate reflection of our implementation and programming. We are kind of creating these site assessments was a very quick response to concerns from CSOs. And when we did that, we didn't take into account all of the issues that we would face. So what we're seeing is that things that we never thought about are really impacting our site assessments. For instance, we didn't realize that if you just got on REDCap and you wanted to try out or see what the site assessment looked like, or maybe you only answered 5 questions and that you got pulled away for something, or maybe your internet went out, that would record that as an actual assessment. So we're kind of dealing with the challenge, and that's only just one instance of trying to decide what is an accurate site assessment versus what may just be a logistical issue. And there are quite a lot of issues. So we're less concerned about the actual 26.9% average, because there are a lot of data issues. And Jessica Rose has spent a lot of time trying to kind of sort through this, which is why we are trying to move away from REDCap in the long run. If we choose to implement this as a metric for quality assessment into something like SIMS, that is really a better platform for it. So again, the 26.9, I don't think we believe that's an adequate or accurate measure of our programming, though we are kind of starting to really focus in on this. We've been working on it in the interagency space, and we're working with countries to identify where the issues are. And I will say that we knew when we created these site assessments that there are some standards that most sites were not going to meet, right? We did not have monitoring systems in place for adverse events. Hardly any countries had that before that, so we knew that would be a section and a question that almost every site did not meet. However, with our community-led monitoring and other processes, countries are really focusing on building these systems. So some of these scores, which we also had foreseen, that's an opportunity for us to continue to improve on our programming and build on those successes. I'll turn it over to Jessica. She can give a bit more of the issues behind the data. So again, I know there's probably concern saying that 26.9% average. That is most likely not the reality, though. Jessica, anything to add?
Yeah, you've covered quite a bit. As Liz mentioned, there's a lot of considerations with the REDCap tool. People may not, they may be just looking at the tool and that will record it as an actual entry, things like that. I think it's important to note that the feedback system we put in place is that information, each of those individual OU reports is fed back to the country teams, to the USAID teams to sit down with the partners and go through and look at what exactly those sites are and those assessments are so that they are making decisions based on full knowledge. The country teams and the partners are best poised to review the assessments and determine whether or not they are in fact even valid, or if it was a question of someone just opening up the tool and looking at it, or if it was perhaps, as I mentioned earlier, a preliminary assessment just to sort of see where you were. So we do not take those numbers, as Liz mentioned, as sort of final. It's really just the beginning of a discussion point between the USAID team and the IP to then determine how valid that information is, and then what to do about it.
Excellent. Ready for the next question? Let's do it. What is the recommended time period to reassess sites after the baseline assessment is completed and remedial actions have been implemented?
Thanks, Susan. We don't have a recommended time period across the board at the moment. That really needs to be decided with the AOR and country team after you've been able to kind of look at your assessment, see where the critical issues are and improvements that are needed, and then put some processes in place to address those issues. And I think there's varying timeframes across countries, and a lot of this is dependent on the AOR or the country team's preference and the standard timeframe that they may have set for this process.
Excellent. And next question is about data collection. And I just lost it. Here we go. Do the requirements for the sharing of data apply to the donor implementing partner, especially when it's the client's name and information? They're specifically wondering with reference to exchange over email.
Okay, I'll answer that one. We do not need to know anyone's name. There's no reason for anyone at headquarters, and I would say there's no reason for anyone on the USAID field team to know a client's name. That is confidential information and should be kept as such. What we do at headquarter level, and what I would recommend at the USAID country level is any of that information can be aggregated or de-identified. So if you feel that you need patient level information, you can certainly de-identify that and give each patient a code number, easily generated. And then even at headquarter level, we do not actually receive individual information. What we receive is generally aggregated data. So we will have, for instance, the number of women 20 to 24 who tested positive through a mobile testing site through this partner. It's otherwise been essentially de-identified at that aggregation level. I will add also, just so you understand it, at the headquarter level, we take data security very seriously. Well, we have, for instance, the geolocations of a number of sites. We don't even share that among ourselves. It is kept close hold with different people in our office, and we do not otherwise share that information or make it easily downloadable. So at all levels, as the data comes up, it becomes less and less specific. And it's really all we need to know. We do not need to know, we definitely do not need to know a client's name. So I just want to be clear that if someone is asking for client names, I think that needs to be stopped. Thank you.
All right, thank you so much, Susan, Jessica, and Liz. We're going to move on to the next section of our presentation. So this is the final part of our presentation in which we want to highlight local partners and their best practices. We have chosen four local partners to highlight today in no particular order. The first of which will be Beza Prosperity Development Organization. This presentation will be given by Israel Lema, and I want to share a few statements about the HIV KP activity that they will be highlighting today. The activity is implemented in 117 subnational units in the Amhara region of Ethiopia. The activity provides integrated HIV prevention, care, and treatment services, including HTS, ART, PrEP, STI management, cervical cancer and screening and treatment, TB screening and referrals. And the activity uses drop-in centers in 18 of the 117 SNUs to provide HIV integrated services for female sex workers and priority populations. So I'll hand it off to you, Israel.
Thank you, Blessing, for the introduction. Good morning, good afternoon, and good evening. Thank you all for joining the webinar. Next slide, please. So our project title is HIV prevention testing and treatment services for key populations in Amhara region, Ethiopia. Our project is a 3-year cooperative agreement. We are a local implementing partners. Our organization is Beza Prosperity Development Organization, a young organization established by a group of committed and talented young professionals. I am the chief of party for this activity. This is one of the strongest USAID community KP program in Ethiopia, and as Blessing introduced, we implement at 117 SNUs in the second populous region in the country, in around 170 SNUs. Thank you. Next slide. So I'm going to, in the next few minutes, I'm going to present our performance during the first 2 quarters of FY21. As you can see from this slide, we managed to test 18,574 key and priority populations, including female sex workers, high-risk men, adolescent girls, and young women. Most of these individuals are female sex workers and high-risk men. High-risk men are clients of sex workers mainly. So we tested 18,574 individuals, and the ICT contribution for this total test we did was around 48%. 9,057 were tested through index case testing partner notification. And as you can see, the HIV positive identification contribution for the total case identified is 81%. 81% of the HIV positive were identified through index case testing. Out of the total 1,868 positives identified, 1,524 were identified through index case testing with a yield of 17%, marginally above the, within acceptable margin of case identification percentage. So the other modalities we used include mobile outreach testing with a yield of 4% and VCT testing with a yield of 3%. Next slide. So this is the ICT cascade data we managed to deliver during the reporting period. As you can see, around 2,454 index clients were provided index case service. This includes the total HIV positives identified during the reporting period. You remember in the previous slide, we identified 1,868 HIV positive cases, and all were provided index case service. And index case clients in the ART cohort with unsuppressed viral and unsuppressed viral load were also elicited, were provided index case testing service. So around 96.7% accepted the service. And one of the interesting data here is the elicitation rate we managed to have was 1 to 4.3 contacts. So one index client elicited around 4.3 contacts, which was encouraging. And we managed to test 85% of the total elicited contacts, which was around 10,344. And of this, around 1,524 HIV positives were identified with a yield of 17%. And of the 1,524 HIV positives, 94.4%, which is 1,439 were linked to treatment. Next slide. So this slide shows one of the best performing sites out of the 18 DICs we have. So these 6 sites managed to demonstrate high performance in ICT-PNS work. So as you can see, the yield ranges from 40.9% to 20%, with a good absolute positive number, from 41 to 93 absolute positive numbers identified. So the activity managed to facilitate cross learning between these high performing sites and low performing sites during the reporting period. Next slide. So the lessons learned during this implementation period include fidelity to ICT-PNS microplanning tool and SOP. We have a standard operating procedure for our ICT work, which focuses on safe and ethical ICT, including implementing 5 Cs and ensuring intimate partner violence screening is properly done during ICT index testing service. And the SOP also addresses some operational issues, including standard script to use when making a call to the elicited contacts. So, the fidelity to this was one of the important things. And we also have a daily micro planning tool, which was helpful to improve performance. The daily micro planning tool details the daily work of the team, including who will call to which client and which geographic location will be covered by which provider, so and so forth. So this was very helpful to improve the performance in ICT PNS work. And the other is continuous engagement with index clients results in more contact elicitation, which means for a number of reasons, index clients might not elicit exhaustively all contacts to be elicited on day one. So the providers continually establish a good rapport with their index client and will continually work with the partner, the index client, to elicit more contacts over the period of time. So which helped us to elicit up to 4 contacts per index client, and which was one of the good lessons we got. And the other is adherence support groups play a key role in convincing index cases and sexual networks to come for HTS index. So, our case managers, in addition to the healthcare providers, the case managers who are PL-HIV positives manage to counsel clients to encourage their partners to come to the testing center, and which was helpful. Especially in our culture, eliciting their sexual partner is very challenging, but the provider's skill to engage the index clients in the elicitation process, and the communication skill of the partner and commitment diligence of the healthcare provider to work with the index clients was very helpful. And in addition, the ICT requires a teamwork. So if we leave the ICT PNS testing service to just one provider, the success rate will be lower. So we learned that working as a team is very helpful. There are very hard to reach geographic locations where the provider has to go and test the elicited contacts, which require a social, psychological, and logistical support by team members. So this was one of the other very helpful lessons we learned. And the other is ICT require a supportive environment. So starting from the top management level, the team working on the ICT PNS work should be adequately supported, should be provided with logistical support. When we mean logistical support, it includes transportation service and phone service to reach out to the elicited contacts, and continuous site level technical assistance and mentorship to review the micro planning process, and to conduct granular data analysis by site was another helpful exercise in our team did. Next slide. This is to show you some of the picture we took from our sites. We apologize for the quality of the pictures. These are ICT corners within the drop-in centers. The ICT corners help us, the healthcare provider, to draw a tree showing the sexual network. So as and when the index client elicit contacts, the elicited contact will be mapped on this tree, and the provider will continue following up the elicited contact, which was very helpful to manage and follow the ICT work. So we call it as a corner in the drop-in center, and this is a hub for cultivating the ICT PNS work at our sites. That's all from me. Thank you for attending the session again, and I would love to hear your feedback and questions. Thank you. Over to you.
Thank you so much, Israel. Susan, did we have any questions come in on this presentation?
Yes, we actually have two questions for you. The first one is that people are wondering what key populations Amhara works with and which subpopulations seem to be having a high yield in your program if you're working with several subgroups of key populations.
Thank you very much, Susan, and thank you for the question. In Amhara, not only in Amhara, in Ethiopia, key populations are limited to female sex workers and prisoners. We are under approving injecting drug users as a key population in this country, not yet approved. So we don't have any other key population in this country for a number of reasons. So the yield is higher among female sex workers. The national prevalence for female sex work HIV among female sex workers is 24%. So those are the main target groups we are working on. The subpopulation groups we work on are clients of sex workers mainly. Generally the HIV prevalence in this country is lower for the other population groups, but we are managing to get up to 10% among the clients of sex worker because we have a successful community index case testing program. So I think this is what I have. If I missed anything from the question, I'll come back.
That's perfect. Thank you. You did share some of the strategies, I believe, but one of the questions was, what strategies have you been using to follow up with contacts since you were able to get an 85% testing of contacts?
Yeah, so we have a lot of community cadres, especially peer educators. So as and when we have these contacts elicited, the healthcare providers will closely work with the peer educators and community outreach workers to map, where the contact elicited are living. So we mainly do phone calls to the partner, but in addition to that, we do a disguise testing method, which means we map where the illicit contact lives or works, and we go around that area, and if the client is not willing to come to the testing center, we go to the community hotspots and we try to find the illicit contact in a disguise approach, and we test them. So we mainly use these two techniques to improve our testing success among the illicit contacts.
Excellent. Thank you so much. That's the end of the questions for this round.
Thank you.
Thank you so much again, Israel and Susan, for getting the questions. We're going to move into our next presentation. The next local partner we'll be highlighting today is Pakashare. This presentation will be given by Cosmas Kamba, who is the Technical Director of Pakashare IHDC/LEAP, and more on LEAP. So LEAP is a 5-year key population intervention implemented in Malawi by Pakashare Institute for Health and Development Communication with support from PEPFAR and USAID. The project aims to improve access to HIV prevention, care, and treatment services among female sex workers, adolescent girls and young women, and their sexual partners. And I'll hand it off to Cosmas for this presentation.
Thank you very much, Susan. Good morning and good afternoon, depending on where you are joining us from. My name is Cosmas Kamba, and I'm from Pakashare IHDC, Malawi. And my presentation today is on improving efficiencies in HIV testing services for key population in Malawi. Next slide. In this presentation, we have key population context for Malawi. We have LEAP activity overview, HIV cascade framework, service delivery models, best practices. Next slide. For the key population context in Malawi, we have a very high burden of HIV among key population in Malawi. HIV prevalence among female sex workers is currently at 62.7% and 17.5% among men who have sex with men and 8.8% among the general population. KP and their partners account for high proportions of new HIV infections and often are faced with poor access to HIV prevention, care, and treatment services due to stigma and legal environment. HIV testing services offer an opportunity and link to KP to prevention and treatment services, and there is a critical need for us to implement innovative HIV testing strategies to reach the hard-to-reach populations and avoid over-testing. Next. For the overview of LEAP activity, between July 2015 and September 2019, Pakachere was a sub-recipient for FHI 360 under the USAID PEPFAR-funded linkages project, but then transitioned to local endeavors for HIV and AIDS prevention and treatment called LEAP in October 2019. The activities are building on the successes and the legacy of linkages, and LEAP aims to improve access to and uptake to HIV prevention, care, and treatment services among female sex workers and most at-risk adolescent girls and young women and their social and sexual networks. It is being implemented in 4 districts of Lilongwe, Blantyre, Nzimba, and Mangochi. Next. For the HIV continuum of prevention, care, and treatment cascade for key population, on the left arm, we have prevention, and on the right, we have care and treatment. So as a KP program, we identify where key populations are and reach them with HIV prevention interventions, whether in small groups or as individuals. And those that test HIV negative are linked to prevention interventions, such as PrEP and condom programming. And for those that test positive, they are enrolled in care, initiated on ART, sustained on treatment, and make sure that they have viral suppression. Next. For core service package at Pakachere, we have peer education, risk assessment, counseling, and risk reduction planning. We have HIV testing services, including index case testing, PrEP, ART, and viral load services, GBV services, promotion of HTS among partners and their clients, condom and lube distributions, sexually transmitted infection management, cervical cancer screening and referrals, family planning services, and TB screening and referrals. Next. Best practices. How are we improving HIV testing efficiency among key populations? So we have tailored HTS to the needs of key population through differentiated service delivery for HIV testing, such as index testing, use of PA cadres to enhance active referrals for HIV testing services, use of HIV testing screening tool, optimization of HIV self-testing and index testing, implementation of innovative testing strategies such as EPOA and risk network referrals, and targeted and data-driven planning for HIV testing services. Next. How are we improving testing efficiencies among key populations? Next slide. As a program, we have tailored HTS services that are delivered to key populations according to their need. And these services are delivered in drop-in centers during outreach and referrals to public or hybrid facilities. At the moment, we have 12 drop-in centers, and on a weekly basis, our teams go around the hard-to-reach hotspots to conduct outreach clinics. And in terms of our HIV testing modalities, we have VCT, index case testing, and HIV self-testing. Next. In this slide, we have engagement of peer cadres to enhance active referrals for HIV testing. So this is a case of FY20, whereby in the first bar is showing that we reached around 13,852 female sex workers with HIV prevention interventions. And out of the 13,852, 7,650 were eligible for testing, while 6,094 were non-HIV positives. And out of the 7,650 that were eligible for testing, we tested 7,161, representing 94% uptake of HTS services. And from those that were tested, 1,353 were diagnosed HIV positive, representing a yield or case detection of 19%, and 1,345 were linked to ART, representing 99%. The strategies that we employed, we have peer educators. Usually they reach female sex workers with HIV testing messages, and they make referrals for the female sex workers at community to come to the drop-in centers or outreach for testing. Sometimes they conduct escorted referrals, and at least 94% of the tests that were conducted, at least 94% of the female sex workers that were eligible for testing had received an HIV test. And from the total that we tested, 2,599 female sex workers were as a result of successful referrals from PEs, peer educators. And out of those that were tested, 446 were diagnosed positive, representing a 17% yield. So this slide, in summary, is showing us the power of peer education in key population. Next. Use of HIV testing screening to improved case detection. And this is a case of FY21. As you see in the slide, we have high testing numbers from October to February FY21. And in March, the project optimized use of HIV self-test screening tool and scaled up HIV self-testing. And we had the lowest number of tested, around 500, but the results were that we had the highest yield from all the months that we started implementation in FY21. The highest yield was in March, up to 34%. So this is as a result of optimization of use of screening tool prior to testing. Next. HIV testing, optimization of HIV self-tests. So if you see from October up to February, we had low numbers of HIV self-tests that were distributed. And in March, we scaled up HIV self-testing. And as a result of the scaling up of HIV self-testing and the screening and the targeting testing and the use of data, our yield or our positivity rate for screening increased from the 1% or 2% that we had in January and February to 7%. So this is the power of screening and the optimization of self-testing. Next. As a program, we also have innovations. And in Q4 of FY20, we had implemented the risk network referral, whereby high-risk key populations were requested if they would get a referral slip for HIV testing for their peers. And some of the FSW got the referral slips and shared with their peers who came for testing. Outreach workers made some follow-ups on the referrals, and this strategy of risk network referral help to improve the yield of up to 28% in the project. Next slide. Thank you very much. Let me acknowledge the Minister of Health and the FHI 360 for the technical support. Thank you very much for listening.
Thank you so much, Cosmas. Susan, do we have any questions for this presentation?
Yes, we do actually. So let's go ahead. We're going to do about 2 questions, and then we'll save the rest until the very end so that everyone can present. And if we have time, we'll make sure to get those questions in then. So the first one is, what strategies are you using specifically to reach out to female sex workers?
Thank you very much for that question. So for the strategies that we are using to reach out to female sex workers, one, we have drop-in centers that we are offering services, integrated services, and we engage peer leaders or peer cadres that mobilize female sex workers to come to drop-in center to access services. And we also have outreach clinics that we conduct on a weekly basis to reach out to hard-to-reach hotspots and female sex workers. And sometimes we also engage or offer some services at the hybrid facilities or the MH facilities for those that are not able to reach to the drop-in center. Thank you.
Thank you very much. And the next question is, what precautions are you taking in consideration of the COVID-19 pandemic?
Thank you very much for that question. So the precautions that we are taking, number one, in terms of the PA cadres, we had oriented all the PA cadres in COVID-19 prevention measures, and we had distributed some PPEs, especially the cloth masks and some hand sanitizer to PA leaders. And we have minimized group meetings. And if there is a meeting that is happening, it's up to 10 people or less that are meeting at a time. So at all times in all our drop-in center, we are following COVID-19 prevention measures. We are screening for COVID-19, and those that are screened or that are at risk that they could have COVID, they are later referred to the Ministry of Health for further investigations. Thank you very much.
Thanks so much again, Cosmas. Next, we'll be going into our third local partner, which is Moy Teaching and Referral Hospital. This presentation will be given by Isaac Kiri, who is the technical lead for community services, which includes PMTCT, VMMC, and KP. So a brief background on the project. The academic model providing access to healthcare, also known as EMPATH, is a partnership between Moy Teaching and Referral Hospital, Moy University, and a consortium of North American universities led by Indiana University. EMPATH has been implementing healthcare activities through various funding sources, majorly PEPFAR and USAID, since 2001. EMPATH Plus has been implementing HIV response activities in Western Kenya since 2012 through the support of PEPFAR and USAID in 10 counties of Western Kenya. They present innovative ways of delivering HTS in one of the most difficult counties in the semi-arid north. So I will pass it off to you, Isaac.
So good afternoon, good morning, and also good evening. My name is Isaac Kirui. Thank you for the introduction. I work with AMBAT Plus program. We did a project on community integrated health service delivery, and the whole reason for it was to improve ART uptake through innovative HTS strategies. Kindly move the next slide. So there is the map of, on the left-hand side is the map of Kenya. AMBAT Plus covers the region where you see the color-coded counties in the legend there. And it was the western side, actually, and also towards the northwestern side there, in the brown color, you can see Turkana County, which is actually vast. On this right-hand side, you can see Turkana County, and the activity was done along the lake zone where you have the blue section of the map. Next slide, please. So the key reason for this activity was actually to break the stagnation in ART coverage. The county has had a stagnated ART coverage of around 34%, and out of the estimated 23,000 people who are living with HIV. Some of the key things that to note about the region again is the vastness, so that even facilities are as far as 31 miles apart. And also we have a community that is nomadic and highly mobile, and a very low health-seeking behavior among men. So we actually wanted an innovation that can increase that ART coverage. Kindly move the next slide. So this activity was fully led by the Ministry of Health at the county, supported by the program. And we had an engagement with the county team led by the Ministry of Health that engaged all the leadership. At sub-county level, we focused on one sub-county, that is Turkana Central Sub-County, where we engaged with the sub-county team and the ward teams to plan and to select the targeted areas where we could conduct this hotspot testing. And at the ward level, which is a lower unit, we also did sensitization of the local administration and the leadership. And that led us to the household level, where we conducted the household mapping and also household screening. Next slide, please. So a key component of this activity was the approach using an integrated approach. This is a community with very high stigma, and as I mentioned, with very low identification. So we looked for related health services that could help us, lead us to the households to be able to provide the key service, which was identification and linkage of those who are positive to care. So we included in our household screening tool, TB screening, pregnancy screening, immunization status screening for children.
Okay, thank you.
And circumcision status for men who are uncircumcised, because within that county, that is one of the priority county in the country where voluntary male circumcision is actually provided as a biomedical service. So we also integrated priority services for those populations that are at the higher risk. And as I mentioned, the main reason for this approach was to reduce the stigma and enhance acceptance, particularly among men. And we also aim to improve the overall health service delivery, looking at the other indicators of health at the household level. And we also wanted to bring services closer to the people, looking at the distances that are there between the people and the facilities. Next slide, please. So we selected 4 community units within one sub-county. In the whole county, we have a total of 146 community units. Key thing to note about this community that was selected, it's a fishing community that lives along the lake, that is highly mobile, and there are a lot of business activities related to fishing that happen within those community units. Next slide, please. So these are the overall outcomes of our screening. The blue bars represent the households that were mapped in the 4 community units, and the red bar represents the households that were reached with screening. And you can see that we had a success. We were able to cover between 55% to 79% of the household in terms of screening out of the ones that were mapped. What you see for Longage, for instance, where we have a higher coverage at 79%, Longage is where we have the main beach. And as I mentioned, the main activity around this place is fishing. So most of the households were committed to fishing activities for men and also for women fishing business. And we were able to reach that coverage in Longage because the households are closer to the beach. And we were able to apply flexi hours so that those who could not be found in the morning could actually be reached in the evening. That was not the case for Kalemabus and Namukuse and the others community units, because the main beaches are far away, and also because the community lives along the lake, and we had displacement of the community because of a rising tide for the lake that is Lake Turkana. So that's where you can see that there was some low coverage in some community units. Next slide, please. So overall, these are the services that we were able to refer clients for. Remember, this was only for a period of 1 month, we were able to identify a very high population of priority clans who are within the fishing community, who are at a higher risk of getting HIV infection, and we referred around 802. We were also able to refer from the households clans for other services, including immunization and also for voluntary male circumcision, those clans who are not yet circumcised and are eligible. And for the main targeted activity, that is HIV referrals, we were able to refer 179. And those who had been lost but were found in the community and brought back were 46. I'll be able to explain the HIV referrals in the next slide. Kindly move the next slide. So overall, we had, and those are the 4 community units, we had a yield of between 1.7% to 3.1%. If you compare that to the facility yield of 0.9%, you realize that it's almost 3 times the yield at the facility level. And you can also see that we managed to cover 57% of the households. Kindly move the next slide. So overall, the activity within that period of time contributed 179 clans out of the 530 that were identified within that sub-county, and that sub-county has 34 community units. So this was a significant contribution of 35% to the total number of clans identified in that sub-county during that period. Next slide, please. So this is a chart that shows the trends of clans who are on ART in 3 key facilities that are located within the community units where the activity was conducted. The upper line represents Kalokol Health Center. The line in the middle represents Long Edge Dispensary, and the line below is Namukudse Dispensary. So you can see that for the 3 facilities, before the community activity and after, that there was a significant increase in the number of clans that are actually initiated and on ART. Next slide, please. So we also conducted an analysis of the outcomes that we saw. On the left-hand side, we looked at the positivity by age and gender, and we can see that there was significant or a higher yield for those clans who were between the ages of 24 to 45 years, a peak in positivity for females at 40 to 44 years, and for males at 45 to 49 years. What this slide tells us is that there is a higher positivity for clans above 24 years. And also on the right-hand side, we looked at an analysis to just look at the testing history and how it is influencing the 2 genders for clans who are above 15 years. And you can see that there were, among the females, there was those who were tested within the last 1 year and who were assessed and found to be at risk, and tested were 54% compared to men who were less at 47%, meaning that men do not test so frequently. And also, if you look at the last section of the slide, the red section, that more men had never been tested at 20% than females at 12%. So meaning this is a strategy that can actually help to identify men. Next slide. So we also looked at positivity by testing history. We looked at those who were tested within the last 1 year, those who were tested older than 1 year, and those who had never been tested. And actually we could see that those who had never been tested were at 4%. And remember that most of these were also men. Next slide, please. So we also looked at the trends over time. If you looked at for the last 2 years between December 2016 to where we have September 2019, where we have 8,210, there was a stagnation in ART coverage. But within the period of almost 1 year, between that period of September 2019 and January 2021, we were almost able to double identification and improve identification and those who are on ART. And if you look at that, we only did hotspot testing in 4 community units out of the 146. There is an opportunity of identifying more if we implement the same in other hotspots. Next slide, please. So what key lessons are we learning from this project? As a project, remember that I mentioned that this is a county that is so vast and where stigma is very high. So using this community testing approach, community hotspot testing approach, we were able to refer clients for other related health services that were actually in need. We were also able to significantly increase those who were identified positive and put them on treatment. And we also learned that for us to be able to reach the others who are not reached at the household level, whom most of them were engaged in fishing activities away or were displaced by water, that we need in future to probably look at more using the flexi hours and other innovative approaches to be able to tailor the testing services to their occupation. So overall, Ministry of Health leadership was very key, and also engagement of leadership for ownership actually was very important, both for ownership and also for mobilization of the households. Next slide. Finally, these are the key recommendations. We feel that for a community like Turgana, where it's so unique, that there are opportunities if we use hotspot testing to be able to identify more clans, and that also this is a proven strategy that we can actually use to reach men who are hard to reach. And especially we saw the data for those who had never been tested. I've attached a screening tool that we use at household level. Next slide. Finally, those are pictures of our field experience. To the left, that is a meeting with the community health workers, orientation on the tools before the start of the activity. And to the right, those are our teams traversing the community units to reach the households. And thank you so much.
Thank you so much, Isaac. Susan, do we have any questions on this presentation?
Yes, we do. We have two questions. The first one is, how do you motivate the use of PrEP among key populations index contacts that tested HIV negative?
Thank you for that question. Within the community units where we were offering these screening services, we have two dices, that is Calocol, and also one which was an outreach called Long Edge. So during the activity implementation, we actually realized that there was a greater need for prevention services, especially biomedical like PrEP, and we opened up a site at Long Edge so that it could be closer to the clans, and it's a fully fledged site that offers all the services with an emphasis and promotion for PrEP using the peers who are working in that community unit. And also that applies for the community unit at Calocol, where we have intensified the use of biomedical services, including VMMC and also PrEP services. Thank you.
Thank you. And the next question is, do you have any economic stability interventions for key populations, specifically for children of key populations?
Thank you for that question. At the moment, we do not have services, economic empowerment services for children or also for the key population in the program. Thank you. But we'll be able to get ideas that can also help us think broadly about it. Thank you.
Thank you very much. And just a quick note that we're going to launch a poll just about the webinar. And the poll will be up for about 20 minutes. So we have until the rest of the webinar to fill it out. Thanks so much.
Awesome. Thanks so much, Susan and Isaac, once again. We're going to move into our final local partner highlight, which is IntraHealth. This presentation will be given by Daniel Lucas, who is the KP Stark Site Coordinator for Gababis. So the Key Population Strengthening Technical Assistance and Response for Sustainable HIV Prevention and Treatment, KP STAR, is funded by USAID and aims to increase access to HIV services for key populations, including men who have sex with men, female sex workers, and transgender individuals. The project's goal is to strengthen HIV prevention for key populations and other HIV KP programs while scaling up innovative evidence-based approaches to reduce the incidence and impact of HIV. The project operates in 10 districts spread across 9 regions with the highest HIV prevalence. So I'll pass it off to you, Daniel.
Hi, Daniel. I think you might be on mute.
Good afternoon, good morning, good evening, everyone, wherever you are. Thank you so much, Blessing, for this IntraHealth Namibia does in Namibia with regards to using of QuickRes as to supporting the demand for online HIV testing services and virtual case management. Next slide, please. So overall, the IntraHealth Namibia, we are saying with our project goal that we want to scale up innovative and evidence-based so we have in Namibia experienced lockdown restrictions, and this obviously has resulted in closure of our hotspots where we are able to find our key populations for service delivery. So hence, we have seen that we can close the gap in service delivery during lockdown when we are using the QuickRes, which is a website online application, which we have adapted particularly to ensure continued service delivery of HIV prevention interventions for key populations, which of course includes ART and PrEP for that matter. The QuickRes app obviously allows us and our clients to book for HIV services online, and our facility-based case managers are remotely monitoring the clients that are on PrEP and ART. They provide phone-based support, tracking of clients who are lost to follow up, and obviously also scheduling and planning the client refills and appointments. The QuickRes was adopted, was developed by FHI 360 through the EPIC project. Hence, we have realized that about 19 countries globally are using QuickRes application. Next slide, please. Now, in terms of what actually QuickRes is all about, QuickRes has got two functions: the function for the client and then the function for the provider. Between September and October 2020, we have uploaded or mapped 51 health facilities on QuickRes app, and this is particularly to provide key services of ART and PrEP. A total of 29 case managers and 40 peer educators have been trained in terms of how to use the app, and they have also been equipped with a tablet that enables them to use the QuickRes app efficiently. Case managers facilitate and manage online appointments and make sure that there are completed referrals information on the app upon as the clients are arriving at the facility, at the clinics. The app has obviously been promoted through various platforms. The stakeholder forums, we have made use of the WhatsApp groups and Facebook, particularly for self-directed HIV risk assessment and clinical appointments. So if you are looking into the client functions, there are some of the functions as to how they can go about as they are directed to then use the app. And then for the provider, we have got the following apps in terms of clinical appointment management, reporting, the DDD, the decentralized drug delivery. We, in terms of live visualization of data, and then we look also in terms of sending SMS blast to clients, client cohorts, to mention a few. Next slide, please. Now, how actually does QuickRes work? The first step actually is that the client would get online and then use the link quickres.org, and then that's where with the first one they will be making their bookings for the particular service that they need, and then secondly, the second picture actually shows us that this person who has made now the appointment reservations would want to then make a reservations for the facility which is nearby to their own area. So the facility information is on. You can read what services the facility is providing, how far is this facility from you, and then the contact details thereof. And then the third picture shows us as to the convenient time for the client. So the client will choose the date, the time that they want to receive the HIV testing services. And then hence the facility will then now start to communicate with the client. Next slide, please. Next slide. So QuickRes obviously makes it simple to view the client bookings. You can see the client information is there to view the bookings of the client, in terms of also assigning the client to a specific case manager, and then also to a peer educator. Next, please. So next. We can see now with this second part, the clinical action, as to how the online case managers, hence then also to record the results of the HIV testing, which could be either noted or positive. Next slide. Next. With regards to the results, now this went already. How far are we with QuickRes in terms of HIV testing? So you can see that about 3,880 appointments have been made. Arrival at the facility, we have got about 46.9% of people who have made reservations that actually arrived at the facilities, and we have provided HIV testing services to them. From them, we have tested 1,010 HIV negative, and then we have tested 238 HIV positive. From them, we have also linked them the next ART cohort as well. But then to particularly show as to from the total number of people that have made reservations, how many have then accessed HIV testing services through QuickRes. Yeah. Next slide, please. Now, as IntraHealth Namibia, we foresee future with QuickRes, particularly with our KB Star project. We foresee already that we will be moving away from the paper-based case management to electronic case management. We are seeing opportunities like efficiency in our case management that will actually improve. With regards to data, the data will be easily accessible. We will ensure obviously high security and high client information confidentiality as well. We are intending obviously to extend the online application to our Ministry of Health and Social Services to get the healthcare workers on board to actually coordinate this application. This is particularly to make sure that we are able to improve the coordination of appointments at the health facility between the health worker, the client, and the case managers of KB Star. Also, we foresee that the online reservations will help, and obviously it has already helped with the decongestion of health facilities, and also it will shorten the waiting period or waiting time that the client will be spending at the health facilities. Having said that, I thank you so much.
Thank you so much, Danielle. We'll move into our final Q&A session for this presentation.
Perfect. We have two questions for Daniel. The first one is, what are the current and specific challenges that you're facing when it comes to collecting this information digitally?
Can you repeat the question again, please? Susan?
Sure, sorry about that. So the question is, what are the current and specific challenges that you're facing in this project?
All right. So for us, because every new project has got high excitement level, and it also has got few challenges as well, which we obviously need to acknowledge. With regards to challenges, we have got two ways. When it comes to the clients, you would realize that some clients wants to use the app, they don't have access to a mobile phone or a, yes. And then besides having a mobile phone, it's the consistency in having data, being online to actually access the services. For the project staff, it is more of the literacy level that needs to be maintained. We need to continuously coach them, mentoring them to make sure that they are making use of the app, and that the app actually gives results to the project. So that's what we are foreseeing at the moment.
Excellent. And the next question is, how are you preventing the double counting of clients? So duplication. Well, I think we may have lost Daniel.
Of clients. All right. So they will be not using the correct name. So it's assist the clients. We make sure that, and therefore someone that has already been registered with the cell phone number and the date of birth will obviously be identified as such. So to make sure that this person is already on the system. Hello, Susan?
Perfect. Sorry, I wasn't sure if you were finished there. Excellent. All right. I think that is it for now. We do have a couple of questions overall that weren't answered by different presenters, but we're going to make sure that we have those answers included on the Q&A document that we'll upload to the website in probably about a week. And that way you can have all your questions answered. So I'm going to hand it back over to Chelsea and Blessing. Thank you so much.
Thank you so much, Susan. So we want to say a huge thank you to the ASAP team, to the HTS team, to all our local partners who presented, and most of all to our participants for joining 2001 ASAP webinar. Just a reminder that you can reach the entire team at htsteam@usaid.gov. And we hope that everyone has an excellent day. Thank you so much.